Marvin Goldfried is a distinguished professor of psychology at Stony Brook University, where he helped to develop the graduate program in clinical psychology. He's the co-founder of the Society for the Exploration of Psychotherapy Integration. Alan Francis is a professor of psychiatry and chair emeritus at Duke, and was chair of the DSM-IV task force. Marvin describes the evolution of his psychotherapy orientation as psychodynamic, behavioral, CBT, and eventually integrative. He practices, teaches, and supervises what works clinically using direct and indirect evidence base. Alan describes his approach to psychotherapy as whatever works, or no one size fits all. He was trained and taught at the Columbia University Psychoanalytic Center, but remains equally interested in brief, supportive, cognitive, behavioral, interpersonal, and family therapies. Please enjoy this week's episode.
Good morning and welcome to Talking Therapy. I'm Marvin Goldfried and my co-host is Alan Francis. Good morning, Alan.
Hey Marvin.
So just before we started recording our discussion here, we were trying to figure out what we're going to be talking about. And it has to do with the notion of schemas, which some people may know more about than others. So hopefully by the end, you'll know something about this. It really, I think it's a trans-theoretical phenomenon. So why don't we start? Let me give a definition now and see if it resonates with you, okay?
Yep.
So on the basis of our past experience, we tend to view other people or ourselves or situations in a certain way. And that way kind of colors what we see and what we don't see. It's kind of an emotional belief system. And I guess a good way to talk about it is politics. People have different types of political attitudes that are based on their past experience. And it's very hard to change them. Similarly, our patients have views of themselves, of other people, developing early, and it's hard to change them. Is there a concept or a jargon within psychodynamic therapies that capture this?
Well, that's straight from psychodynamic therapy. And not surprised Beck was an analyst. That's a nice, neat, short statement of the most essential aspect of psychodynamic theory of human behavior and perception. And it's the window into what a psychodynamic therapist would want to be working with the patient on, trying to see how those schemas are no longer the most accurate and most adaptive way of seeing and understanding present-day experience, the way the past distorts the present.
Is there a label or jargon?
Well, I think if there's one word that would most encompass it, would be transference. The patient has transferences to current situations that are tremendously influenced by past experiences. That's true in therapy, transferences to the therapist, but it's also true outside of therapy. So what you're saying is the essence of psychodynamic theory. It's not something different than psychodynamic theory. It's just a nice, neat way of expressing the most essential concept in the psychodynamic theory of perception, attitudes, relationships, and it's the key to therapy, trying to help to reduce the distortions in the schemas the patients have.
Right. And this certainly is very much core to CBT and also experiential work. So this is good. It's a good topic. And again, we were separated by different labels, but we're really talking about the same phenomenon. So let me give you an extraordinarily low-tech way of viewing it. And this is what I tell patients, that we all have little file drawers in our head, or file slots. And when something occurs in our life now, we sort it into that file slot. So-and-so is doing things because he or she is mean. So we have this view, the schema of another person as being mean. And whatever they do, we see it as being mean. And sometimes people have very big slots. And that means that a lot of what they see gets categorized in a certain way. Does that help or does that confuse?
It's exactly the way a psychodynamic clinician would see it. There's no distance. I think the one difference between the one contribution that was enormously distant from psychoanalytic ways of using the concept of schemas was that Beck at the beginning focused much more on the here and now and the present and on current symptoms with less discussion of the past. I think that in cognitive therapy at the beginning, partly because it was a research vehicle as well as a clinical tool, cognitive therapy at the beginning advertised itself as a very short-term therapy for most people. I think one of the interesting things that happened in the first 2 decades of cognitive therapy was that reaching into the past more to see its influence on the current schemas became more a part of treatment, just as had happened with psychodynamic treatments, originally symptom-oriented and brief in the early 1900s. Mm-hmm. And by the 1930s, long-term and very intensive. That cognitive behavior therapy, I think the average in the beginning was just about 12 sessions, and gradually the average number of sessions became longer and longer because the cognitive therapists, sort of merging with the psychodynamic therapists, began to realize that you couldn't just discuss the present of schemas, that for many people, you also had to see how they had emerged originally.
Yeah. There was a psychologist, Sarensen, that once wrote an article criticizing CBT, saying CBT therapists don't recognize that cognitions have histories.
Exactly.
And knowing the cognition in the here and now can be very well informed by knowing the history of how it developed.
It's sort of interesting in terms of your trans-theoretical efforts to integrate psychotherapies, that when people are actually working with patients, they begin to discover there are common elements that they can't avoid, no matter what their original theoretical orientation was. So Freud originally used to see his patients for brief treatments, many of them, not all, but many of them for brief treatments. The treatments extended because the awareness increased that there were character problems, that they were more pervasive than symptoms, and that they had a long history. And psychoanalysis then went overboard on overly long, overly intense treatments. But cognitive behavioral therapy started with the bias, we're going to do things in the here and now very short, and realized that you couldn't completely eliminate the past, right, and expect to deal well with the present.
I think the interesting thing that allows for this change and development among therapists and becoming more similar is that our patients don't read the professional literature. So they don't know the way they're supposed to behave according to theorists. They just behave in a way that they have constitutional tendencies to behave, or the way they've learned to behave. And that has nothing to do with theory. A theory is an attempt to better understand this kind of thing. But you mentioned cognitive therapy. And that's very interesting, because when I teach cognitive therapy, I say there are certain ways that people view the world, okay? They have cognitions, and these cognitions are manifestations of more basic schemas or tendencies to view the world, which are based on the past, but the present is different. So what you need to do to change the schema is to provide evidence that contradicts the schema.
And I think that's the basic, if you had to pick one basic sort of way of expressing what happens in psychotherapy, it would be exactly that sentence, adding on definitely corrective emotional experience, because correcting the schema is part of a corrective emotional experience, and change behaviors. That you're helping the person to get less distortion in the way they see the world, and the way they feel the world, and the way they behave in the world. Right. All three aspects go together.
So the question then becomes, what is the quote evidence Should it be logical evidence or should it be personal experiential evidence? Should the therapist say, well, that doesn't make sense, does it? Why doesn't it make sense? Which is focusing on the logical, or on the basis of situations you've been in, personal experiences you've had. Are there any of these that contradict this view? And my feeling is that it should be the personal experience rather than logic.
Well, I think it depends on the person. I think that I agree with you completely, except that for some people, maybe the avenue to experience is through logic, and they won't be able to really understand what you mean until you're able to point out part of the illogic in the way they see the world now. I think that for me, it's behavior, emotion, and thoughts go very closely together.
Yeah.
Dealing with just one of the tripods, you're going to be maybe lost down that particular rabbit hole without integrating all three. And I think that the way you get to it may vary with different patients. So that I much prefer the person who can come up with experiential examples that contradict. But some people can't do that until they first understand that they're not seeing the world very clearly, not seeing the.
Here's the interesting thing, and I don't know if this is an orientation difference or not, or at least in the classic clean, when therapy schools were clean, which I think is no longer the case. Should this contradictory experience be focus on the past evidence, or should it be new experiences? So it's like something occurred in the past, but the person never really used that personal experience as evidence to change their schema. Let me give an example, okay? My mother, my father, I have a schema that they're really selfish and don't want to give me what I need because they've just never been around. They're always doing something else, not taking care of me. So this is past behavior that is interpreted as being consistent with the schema. However, the reason they may never have been around was they maybe were a single parent and they had to work 2 jobs and had to put money away for the education of the patient. Reviewing this in a different light can take something that was not contradicting schemas and getting it to contradict schemas. So it's kind of it's transforming or reframing or reattribution of the past. Versus go out and try this and have a corrective experience next week.
It's an interesting question. And the way I've experienced it, the rubber hits the road for me is when I want to refer someone for therapy, who do I refer them to? What kind of therapist? What kind of person? And the 2 types of people I don't want to refer to are, on the one hand, the person who only dwells on the past and is too focused on prior experience, fascinated with childhood, not too interested in how the person's living their life today. I don't trust therapists like that. They tend to get to very long therapies that often are not dealing with the real world problems.
And that's the traditional psychodynamic.
Yeah, that's not the traditional, but the dumb psychodynamic.
Okay.
The dumb psychodynamic, taking things too literally, would tend to prejudice the past in favor of the present.
Yeah.
On the other hand, I don't trust therapists who don't have the understanding that you're expressing, that there is a past, that the past is never really past, that it's always living in the present, and that you need to, in order to be able to get the person to have a rounded view of themselves in the world, it's not just going to be a distortion in this minute. They're going to have some degree of understanding that they've carried this distortion over a long period of time. I'd like someone who can flexibly move from past to present, from experiences that happened long ago to experiences that happen today, and tie them together.
Yeah.
And do this without expecting that every treatment will last 5 years.
So the dumb CBT therapist is the one that doesn't deal with the past, only the future.
Exactly.
So here's a beautiful example of therapy, if it's done within the confines of a particular school focuses more on doing what the theory says than necessarily what the patient needs in order to improve.
Yeah, or another way of putting it is that the dumb therapist is the one who stick to the school really closely.
Yeah.
And the smart therapists are going to look a lot alike. You're not even going to be able maybe to tell the difference because they're smart and being able. The definition of a smart therapist is someone who can flexibly integrate and not be stuck with the extreme of any model.
Right.
Definition of a dumb therapist is someone who is stuck in the model so much that he loses sight of the needs of that patient, and he's like a hammer ready for that particular nail he's gonna hit home.
So let's say that we have a smart therapist that is willing to dip into the past and focus on what could be done in the future. Here's a question that has always puzzled me. On the one hand, you have a schema, and this is like theory. You have a theory of the world, or scientist has a theory. And then when the only way a theory can change is by contradictory evidence. The question, and the question becomes, how much contradictory evidence is needed in order to change the schema?
I understand.
If a person comes in and they have this belief system, how many corrective experiences do they need? Or how much do you have to reevaluate and reframe the past in order to change that maladaptive view?
Yeah, I have a fair amount of experience with this because I've done work in emergency rooms. I've done a lot of brief therapy, but I've also done a fair amount of long-term therapy.
Mm-hmm.
And to me, the variable is much more the patient than the therapist.
Mm-hmm.
So like for some people, it changes in a 15-minute emergency room visit. Somehow or other, those magic moments, you say something and the person gets it and they realize that they've been seeing things completely, and it's just one contact of 15 minutes, whereas I've had the experience of people not getting it over many years. So it's a lot of the variance in whether it works quickly or requires constant repetition, often futile repetition, depends on the patient, where they are in their life, the matchup between the therapist and the patient. Do they really hit it off in a special way? Are there very clear examples of the distortion in this moment that hit you in the eye, or is it so subtle that maybe people aren't going to catch it right away? But I think we always should be striving for, we can hopefully make this happen. We should never give up on the idea that we can make this magic moment happen.
Yeah. So a couple of points here that I'm going to follow up on. What you're saying is something that a conclusion we often come to in our discussions. So the answer to the question, how much new experiences or reevaluation of past experiences are needed, it depends. This becomes a key clinical and research question that people are not addressing as much as they need to in research. The research is to demonstrate my theory is better than yours, or my school is better than yours, rather than answering the question of depends and providing the clinician with information about, well, here, what does it depend on? It depends on how early the onset of these early experiences that created the schema. How severe were they? So chronicity, severity become important. The type of the person, characteristics of the person as an individual. Some people, can see things better or can change, are more flexible or intellectually more flexible in the way they see things. These are the variables that need to be studied. And this is the kind of research that the clinician would very much welcome, I think.
I love the idea of it depends as one of the great principles of, if you wanted to teach one great principle to all trainees about how they should do psychotherapy, you would get them attached to the notion that it depends. And it depends a little bit on you, but it depends a lot on the patient and the patient's situation in life. I think the first book I ever wrote, which was 40 years ago, more than 40 years ago, was called Differential Therapeutics.
Exactly.
Be sort of a congener to differential diagnosis, that when you're planning a treatment, you shouldn't assume that everyone within a given category will require the same treatment, because even if you meet a given diagnosis, what treatment's best will depend on so many variables beyond the diagnosis that are more well covered by formulation. The trouble with your wish about research is that it's just so complicated to do research on this. It would require absolutely enormous samples. There are so many contaminating variables that you can answer some questions about how it depends, but a lot of it is going to be lost in the noise.
But I think, yes, it is complicated. But it's like, the person who's looking under a street light at night for his or her keys. And somebody comes over and it's like, you lose your keys. Yeah, where did you lose it? It was across the street, but the light here is better.
Right.
And this is the kind of things that go on. The kind of research that has been done over the years has not focused on it depends. And I think clinical trials really put a stop to a lot of the process research that would follow from what you wrote in that book on differential therapies. It's the essence of it. And that's what clinicians do all the time.
But I guess the question I have for you, Marvin, in the absence of that research, how do you teach it? It depends.
Well, you can do quick and dirty research. You can present very specific case histories and do surveys of clinicians. You can get 1,000, 2,000 people responding online. We can do this stuff now.
I think that's really, and you are doing it. I think that's very valuable.
Yeah.
Because although it has the disadvantage of the variables are uncontrolled, it has the tremendous advantage of being experienced close to actual clinical practice.
Exactly. It's dealing with the phenomenon. And if 1,000 clinicians tend to agree that, well, when you've got a depressed person who's in this particular situation, and the onset of depression was not until age 50, and then you just go on, and this is what's going on interpersonally in the person's life. What are the variables, or what's the differential therapies here? And to somehow present it in a way without jargon, or present videos of it. This is very easily done.
And I think it's a wonderful approach, an approach that's made necessary by the difficulty of doing controlled research on complicated topics. The only problem with it is, and it can be a major problem, is that you're never sure that the sample of convenience of clinicians who take the survey represent the entire universe of well-informed opinion.
Right. But then you replicate it and you do better controlled studies. But at least you're looking in the place where the keys were lost.
Right.
Not just simply doing a knee-jerk clinical trial, which reveals something or other. Reveals that therapy can work, but it doesn't really inform the clinician about what to do.
I think the note I would end on, and I think this has been a valuable discussion, it's helped me understand things better. I think the note we should end on, because we can get lost in the complexity and make it feel, if it's going to be hard for research to guide practice, then it's going to be every man for himself. I think the middle position in terms of research is the one you're taking, that we can find a consensus, perhaps, of informed clinicians. And the important point for training programs is to not get stuck in doing dumb teaching that's a hammer that uses the same techniques for every nail, but rather the training program should respect the concept of it depends.
Mm-hmm. That's a good note to end on.
Okay. See you next week, Marv.